Welcome back to the Deep Dive. Today, we are tackling a part of the human body that I think, and I'm fully including myself in this, we tend to drastically underestimate. We usually think of it as just plumbing. You know, it's a chute. You put food in the top, gravity does its thing, and it lands in the stomach. Simple.
That is the classic oversimplification. And honestly, if you are a surgeon or you're training to be one, that oversimplification is actually, well, it's dangerous.
Dangerous.
It is. It's the kind of thinking that leads to complications. Big ones.
Exactly. We are talking about the esophagus. And specifically for this deep dive, we are jumping into Chapter 66 of the 28th edition of Baily and Love's Short Practice of Surgery.
The Bible for surgical trainees across the globe. It really is.
It is. And looking at this chapter, it becomes clear very, very quickly that the esophagus isn't just a passive food pipe.
Not at all.
It is a high-pressure zone, it's a winding road, and frankly, it is filled with anatomical landmines for any surgeon who goes near it.
It's an unforgiving organ. I can't stress that enough. The margin for error when operating on the esophagus is razor thin.
Why is that?
Well, just think about where it lives. It's right in the middle of the mediastinum. You've got the heart, the great vessels, the lungs, and all these critical nerves packed in around it. One wrong move, and you aren't just dealing with a leak, you are dealing with a catastrophe.
So here is our mission for today. We have gone through Chapter 66, the esophagus. And we aren't just going to regurgitate the text to you. That would be boring, and you can do that yourself.
Right. This is about interpretation.
We want to interpret it. We want to build some mental anchors for you, things you can hook the details onto.
Think of this as a companion piece, a ready reckoner, if you will.
A ready reckoner. I like that.
If you're a medical student prepping for rounds or a resident cramming for exams, this is designed to help you synthesize the high-yield facts. But please, this is the scaffold. You need to go read the actual text in Baily and Love for the fine print.
Consider this your audio roadmap. We'll build the structure together, and then you can go fill in the bricks with the textbook.
So what's the plan?
So here's our plan. We're going to start with the anatomy, specifically the dangerous curves in the nerves. Then we'll look at physiology, the pressure zones. We'll move on to motility disorders, what happens when the rhythm fails. We've got a heavy section on emergencies, things like perforations, and we'll wrap it all up with tumors and the big surgeries.
It's a journey from the neck right down to the abdomen.
Let's start the car then. Section 1, the winding road, applied surgical anatomy.
I like that image of the winding road because, look, the first mistake people make is thinking the esophagus goes straight down. It absolutely does not.
Right. Baily and Love gives us coordinates. We start at the cricoid cartilage, what that corresponds to the C6 vertebra level. That's our starting line.
C6. Got it.
And we end at the esophagogastric junction, or OGJ, which is way down at T11.
So C6 to T11, that's the span. But between those 2 points, like you said, it's not a straight line. It's more of a chicane.
Let's visualize this because this is so important. Imagine you are driving, a tiny car down the neck into the chest. As the esophagus starts, it immediately leans to the left.
Okay, so in the neck, we are leaning left.
Then, as it enters the midchest, the thorax, it curves back towards the right.
And why does it do that? Is something pushing it?
Something is absolutely pushing it. The aortic arch. It's this huge structure that's taking up space, and it basically shoves the esophagus over to the right.
Okay, so we got left in the neck, push to the right in the midchest. What happens next?
And then as it gets to the lower thorax to punch through the diaphragm and find the stomach, it edges back to left again. So the pattern is left, right, left.
Left, right, left. That is a fantastic mental anchor. But let's apply this. Why does a surgeon care about a few degrees of curvature? What's the so what?
It completely dictates your surgical approach. Because of that first lean to the left in the neck, if you need to expose the cervical esophagus, say for a trauma, or a foreign body, or a tumor, it is generally much easier to approach from the left side of the neck.
Because it's physically closer.
It's physically closer to the surface on that side.
Yeah.
You don't have to dig as much.
That makes perfect sense. You just follow the anatomy. If it leans left, you cut on the left. But there is a trap on the left side, isn't there? A pretty significant one.
The nerve trap. This is so crucial. We are talking about the recurrent laryngeal nerves.
The nerves that control the vocal cords. Damage one, and the patient is hoarse for life. Damage both.
And you have a catastrophic airway obstruction. And Baily and Love makes a very specific, very important distinction between the right nerve and the left nerve here.
It does. On the right side, the nerve loops under the subclavian artery. It often sits a little bit away from that groove between the trachea and the esophagus, gives you a tiny bit of breathing room. But on the left side,
it's a completely different story.
on the left, the nerve loops way down under the aortic arch in the chest and then comes back up. And critically, it is opposed closely to the esophagus and trachea. It's tucked right into that tracheo-esophageal groove.
So let me get this straight. The left side is easier to access because the esophagus leans that way.
Right.
But it's also the danger zone for nerve injury because the nerve is hugging the tube much tighter.
Exactly. It's a classic surgical trade-off. Easier access, but a higher risk. When you are doing something like a cervical lymphadenectomy, clearing out lymph nodes, you have to be hyper-aware of that left recurrent laryngeal nerve. You can't just blindly sweep tissue aside.
Now, along this winding road, there are also a few traffic jams. The text mentions 3 constrictions.
Yes, these are the spots where the tube narrows naturally. And clinically, these are the spots where things get stuck.
Right. If a kid swallows a coin or an adult swallows a big chunk of steak without chewing.
These are the 3 places it's likely to lodge. Every time.
Let's list them out for everyone.
Okay, number 1 is right at the top, the upper esophageal sphincter, UOS, specifically the cricopharyngeus muscle.
The gatekeeper.
Right. Number 2 is in the middle of the chest, where the aortic arch and the left main bronchus cross over the esophagus.
So they physically squish it.
They physically impress upon the tube, narrowing the lumen. It's an external compression.
And number 3?
Has to be the bottom, the lower esophageal sphincter, LOS, right where it goes through the diaphragm.
Okay, let's pause right there. I want to do a quick check-in. We said we'd do this to help retention, so if you're listening, see if you can answer this before we do.
Let's test the knowledge.
Check in. Question 1. Pause and think. If you are approaching the cervical esophagus surgically, which side is generally easier to access due to the anatomy, and on which side is the recurrent laryngeal nerve hugging the esophagus most tightly, putting it at greater risk?
Give you a second. And the answer is, access is easier on the left, but the nerve is also tighter and more at risk on the left.
So remember, left for access, left for danger. Got it. Let's move to section 2, the gatekeepers, sphincters, and the OGJ. We mentioned the UOS and the LOS. Baily and Love highlights a big difference between these two.
It's a massive difference. It's fundamental. The upper sphincter, the UOS, is a structural sphincter. It's made of striated muscle, that skeletal muscle.
So it's tangible.
Correct. It's formed by the inferior pharyngeal constrictor and the cricopharyngeus. You can see it, you can dissect it. It's a real physical ring of muscle.
And when that goes wrong?
Dysfunction there is what leads to Zenker's diverticulum, that pharyngeal pouch. If that muscle doesn't relax properly when you swallow, the pressure from inside literally blows out the wall just above it.
Okay, so that one's straightforward. Now contrast that with the lower sphincter, the LOS. The text calls this a high-pressure zone, but it describes it almost like a ghost.
It's a physiological sphincter, not an anatomical one. That's the key takeaway. If you cut open a cadaver, you will not find a thick band of muscle at the bottom of the esophagus like you do at the top. It's not there to see.
So if there's no visible ring, how does it even work?
It's a mix of things. There's some intrinsic muscle tone in the esophageal wall itself, but a huge part of its function is the pinch from the crura of the diaphragm as the esophagus passes through.
Ah, so the diaphragm acts like an external clamp.
Exactly. We know it's there because of manometry measuring the pressure. That test proves there's a valve. It functions like a valve, but it just doesn't look like one.
And this ghost valve is where so much of the pathology happens. If it's weak, you get reflux.
Horrible GRD. And if it's too tight and it won't relax, you get achalasia.
We'll get to achalasia in just a moment, but first we have to define the end of the line, the esophagogastric junction, the OGJ.
Right.
The text offers 3 different definitions for where the esophagus ends and the stomach begins. Why is it so complicated? It seems like it should be obvious.
Because nature rarely draws straight, neat lines. So you have the anatomical definition first, where the tubular esophagus meets the saccular or pouch-like stomach.
Simple enough, seems logical.
Then you have the histological definition, which is where the squamous mucosa of the esophagus switches over to the columnar mucosa of the stomach.
Doesn't that line move?
Precisely. In conditions like Barrett's esophagus, which is caused by chronic reflux, the stomach lining actually creeps up the tube to protect itself from acid. So the histological junction, the so-called Z-line, moves up into the chest. You can't rely on that for anatomy.
So what does the surgeon or the endoscopist actually use in practice?
They use the endoscopic definition. This is the practical one. Imagine you are looking down the scope. The stomach is lined with rugae, those big, thick, wrinkly folds.
Right.
The esophagus, by contrast, is a smooth tube. The OGJ is simply defined as the top of the gastric folds.
So your visual anchor is where the wrinkles stop, the esophagus starts.
That's it. It's that simple. There's also another marker mentioned, the palisading vessels. These are fine longitudinal veins you can see in the lower esophagus. When those end, you know you're at the junction.
Okay, so we know the anatomy, we know the landmarks.
Yeah.
Now let's talk about when the machinery breaks. Section 3, motility disorders, when the rhythm fails.
This is where things get really interesting physiologically.
The text talks about the diagnostic toolkit, and it seems like the good old barium swallow isn't quite enough anymore.
Barium is great for giving you a roadmap for seeing the overall shape, but for function, the gold standard is high-resolution manometry, HRM.
And what does that do?
It's a catheter with sensors all along it. It measures the pressure waves, the peristalsis, throughout the entire tube simultaneously. And we use something called the Chicago classification to label and categorize what we find. It's a very systematic approach.
We also saw a mention of a newer tool, FLIP, functional lumen imaging planimetry. That sounds incredibly high-tech.
It's a fascinating piece of kit. Imagine a catheter with a balloon on the end. You put it in the esophagus and you inflate it. It measures the cross-sectional area and the pressure inside the balloon at the same time.
So it's testing the stretchiness of the wall, the compliance.
Exactly. It measures distensibility. How stiff is the wall? It's very useful because it gives you a dynamic picture of how the lumen behaves, not just how hard it can squeeze.
Okay, let's talk about the big diagnosis everyone thinks of with motility, achalasia.
Achalasia. The word basically means failure to relax. The LOS, that lower sphincter, stays clamped shut, and the peristalsis, the normal squeezing wave of the esophagus, stops working.
So food just...
sits there. It just sits there. It ferments, it rots, and over time it stretches out the esophagus until it can look like a sigmoid colon just sitting in the chest.
And on a barium swallow, you see that classic sign.
The rat's tail, or bird's beak. A massively dilated esophagus tapering down to a tiny sharp point at the bottom where the sphincter is closed.
But here is where the Chicago classification gets granular, right? Because there are 3 types of achalasia, and knowing the difference is critical for treatment.
It really is. Let's break them down.
Okay, type I.
Type I is the classic. The esophagus is basically a dead tube. There's no squeeze, no pressure buildup at all. It's just gravity working against a closed door. Food goes down and stops.
And type 2.
Type 2 is really interesting. You get panesophageal pressurization. This means the whole tube squeezes or pressurizes at the same time. It's not a wave, it's just a simultaneous clamp down.
And the text says, this type has the best surgical outcome. That seems counterintuitive. Why is high pressure a good thing?
It's because it means there is still some muscle integrity left. The muscle works, it's just completely uncoordinated. So if you go in and you surgically cut the valve at the bottom, gravity and that residual pressure work together to help clear the food.
That makes sense. And type 3.
Type 3 is spastic. You get premature, jerky, high-pressure contractions. This is the hardest one to treat.
Why?
Because even if you cut the valve at the bottom, the pump above it is still broken and spastic. You might fix the blockage, but the patient still has these painful, useless contractions.
I want to bring in a case study here, a fictionalized one from the text, to show why you have to be so careful with this diagnosis.
Go for it. This is a crucial point.
Picture a patient, maybe 60 years old, presenting with dysphagia trouble swallowing. They've lost a lot of weight fast. You do a barium swallow, and it looks exactly like achalasia. You see the bird's beak.
Okay.
So you go to do an endoscopy, but you can't get the scope through the tight spot. Everything is pointing to achalasia.
Classic case, right?
That's what you'd think.
Yeah.
But the text warns about something called pseudoachalasia.
This is the nightmare scenario for a gastroenterologist or surgeon.
You send that patient for a CT scan, just to be sure, and what you find is a tumor at the OGJ. The cancer is wrapping itself around the lower esophagus, strangling it from the outside.
So it mimics the look of achalasia on the barium swallow, but it's actually a malignancy?
The lesson being, never, ever assume.
Always investigate thoroughly. If you can't easily pass the scope, or if the patient is older and the onset of symptoms was rapid with weight loss, you have to rule out cancer.
Before we leave motility, we have to mention the other spasms. We have the corkscrew esophagus.
Diffuse esophageal spasm. The barium swallow literally looks like a corkscrew because the circular muscles are contracting in this bizarre, spiral, uncoordinated fashion.
And then the jackhammer.
Jackhammer esophagus. It is exactly what it sounds like. Hypercontractile. The pressures measured on manometry are off the charts. It's extremely painful for the patient.
Okay, checking question 2. Let's pause again. 2 parts here. First, if a patient has a corkscrew appearance on a barium swallow, what is the likely diagnosis? And second, thinking back to the Chicago classification, which type of achalasia generally has the best surgical outcome?
Okay. The corkscrew appearance indicates diffuse esophageal spasm. And the achalasia with the best surgical outcome is type 2, the one with panesophageal pressurization.
Right. Moving on to section 4, fixing the flow treatments for achalasia. So we have a patient, the valve won't open. How do we fix it?
You have 2 main strategies.
Yeah.
You can force it open or you can cut it open.
Let's start with force. What does that involve?
That's primarily pneumatic dilation. You put a specialized balloon down through an endoscope and you inflate it right at the sphincter to literally tear the muscle fibers.
Sounds a bit brutal.
It is, in a controlled way. It works pretty well, but it's not always permanent. The muscle can scar back down.
And what about Botox?
Botulinum toxin, yeah. You can inject it directly into the sphincter to paralyze it. It forces the muscle to relax. The big problem is durability.
It wears off.
It wears off fast. The text says it works great for about 3 months. Maybe 70% of patients get relief. But by a year, that drops to 40%. It's really just a temporary fix, mostly for patients who are too frail for surgery or if the diagnosis is still in doubt.
So if we want a permanent fix, we have to cut. The text details Heller's myotomy.
The surgical gold standard for a long time. You go in, usually laparoscopically now, and you surgically cut the muscle of the lower esophagus and the very top of the stomach, the gastric cardia. You literally slice the sphincter open.
But there's a huge catch. If you slice the valve open, you've just destroyed the body's natural anti-reflux barrier.
Exactly. You cure the dysphagia, the swallowing problem, but you give them terrible GRD in return. The stats say about 40% of patients will get significant reflux if you just cut the muscle and do nothing else.
So what's the safety valve the surgeon adds?
You have to add a fundoplication. You take the top part of the stomach, the fundus, and you wrap it partway around the bottom of the esophagus to create a new low-pressure valve.
But Baily and Love has a very, very specific warning here. Do not do a complete 360-degree wrap.
This is absolutely critical. A Nissen fundoplication is a full 360-degree wrap. It's a great operation for regular reflux patients who have a normal working esophageal pump.
But for an achalasia patient?
For an achalasia patient, their esophagus has no pump. It's weak. It relies on gravity. If you put a tight 360-degree collar around it, the food won't go through. You're just trading one type of blockage for another.
So you have to do a partial wrap.
Yes. An anterior wrap, which is called a door, or a posterior wrap, a toupee, they're usually 180 or 270 degrees. They're loose enough to let food through via gravity, but just tight enough to stop most of the acid from coming back up.
Now, there's a new kid on the block. PEO.
Peroral endoscopic myotomy. This is the tunneling technique. It's really clever.
No skin incisions at all?
None. You go down the throat with an endoscope, make a tiny cut in the mucosa, the inner lining, and then you tunnel between the layers of the esophageal wall.
Yeah.
And once you're in that tunnel, you cut the muscle from the inside. Then you close the little entry hole with a clip.
It sounds incredibly elegant. What are the advantages?
It is, and it's fantastic for type 3 achalasia, the spastic kind, because you can make a really long cut up the esophagus to deal with all those spasms much longer than you can from the outside.
But there has to be a downside.
The downside is reflux. You can't add a fundoplication. You can't build that anti-reflux barrier from the inside. So reflux rates after PUEM are quite high.
So it's a trade-off again. Better cutting, potentially, but worse reflux.
Medicine is always about trade-offs. Always.
Let's shift gears to a much scarier topic. Section 5. Catastrophes, perforations, and injuries. These are the calls you do not want to get at 3 a.m.
No, you don't. And the esophagus is unique. It doesn't have a serosa that's the tough, shiny outer layer that the rest of the bowel has.
And what does that mean in practice?
It means if it leaks directly into the chest, into the mediastinum. It causes mediastinitis, which is an overwhelming infection that is incredibly lethal and happens very, very fast.
The most dramatic example of this is Borhave's syndrome.
Spontaneous perforation. The classic story is someone who has had a large meal, drinks too much, and then has a forceful vomit against a closed glottis. The pressure builds up instantly and pop. The esophagus bursts.
And remember our anatomy lesson. Where does it tend to blow out?
The left side, remember we said the lower esophagus edges left and is anatomically less supported? That's the weak spot.
And the symptoms. The text mentions a classic triad, Mackler's triad.
This is the clinical anchor. If you see this, you have to think Boerhaave. The 3 signs are 1, vomiting, 2, severe chest pain, 3, subcutaneous emphysema.
That last one's just wild. Air under the skin.
Yes. The air escapes the ruptured esophagus, tracks up the mediastinum into the neck. When you press on the skin of their neck or upper chest, it feels like bubble wrap. It crackles. The medical term is crepitus.
And if you listen to the heart with a stethoscope,
you might hear Hammond sign. It's a crunching sound with every heartbeat. That's the heart literally beating against air-filled tissues in the mediastinum. It is a sign of doom if not treated immediately.
Why is it so deadly so fast?
It's because you are pouring gastric acid, bile, and half-digested food directly into the left pleural cavity. It causes a massive chemical and bacterial inflammatory response, leading to sepsis and shock within hours.
Now compare that to Mallory-Weiss syndrome, also caused by vomiting, but much, much less scary.
It's a completely different level of injury. A Mallory-Weiss is a tear, not a full-thickness burst. It's a tear in the mucosal lining right at the junction.
So the wall of the esophagus is still intact.
The wall holds, just the lining tears. The patient vomits bright red blood hematemesis, which is, of course, scary for them, but it usually stops on its own. If it doesn't, it can be treated endoscopically with clips or adrenaline injection. It's almost never a surgical emergency like Boerhaave's is.
One last emergency category. Corrosive injury. Swallowing things like drain cleaner, acid, or alkali.
The first golden rule here is airway first. If the patient is hoarse or has stridor, it means the laryngeal inlet at the top of their airway is burned and swelling. They could swell up and choke in minutes. You need to secure that airway early.
And what's the big don't in this situation?
Do not perform gastric lavage. Do not try to neutralize the acid or alkali.
Why not? That seems like the first thing you'd want to do. If they swallowed acid, why not give them an alkali to balance it out?
Simple chemistry. An acid-based neutralization is an exothermic reaction. It generates heat. You will literally boil their already damaged esophagus from the inside out, causing a much worse thermal burn on top of the chemical one.
And putting a tube down.
Risks punching right through the weakened necrotic wall. So you just support them, give them IV fluids, pain relief, and wait for the damage to declare itself.
Okay, time for our last check-in. Check-in question 3. A patient has been vomiting violently. They now have a crunching sound over their heart and air under the skin of their neck. Is this Mallory-Weiss or Boerhaave's? And which side of the chest is likely full of fluid?
A moment to think. The crunching sound and the air under the skin are the dead giveaways for Boerhaave syndrome, the full rupture, and anatomically, it is almost certainly the left side of the chest that's filling with gastric contents.
We're in the home stretch now. Section 6, tumors and the big surgeries.
Esophageal cancer is a grim topic, but surgically, we tend to classify it into 2 main buckets based on histology.
Squamous cell carcinoma and adenocarcinoma.
Squamous cell is, you could say, the old-school esophageal cancer. It's linked to smoking, heavy alcohol use, even things like drinking very hot beverages and eating pickled vegetables.
Yep.
It usually happens in the proximal or middle part of the esophagus.
And adenocarcinoma.
That is the modern epidemic. Its rise has mirrored the rise in obesity and reflux disease in the Western world. It is strongly linked to GERD, which leads to Barrett's esophagus, and then to cancer.
And because it's caused by reflux?
It almost always happens at the distal end, right near the OGJ where the acid is.
When it comes to taking these tumors out, an esophagectomy, it is a massive, life-altering surgery. The text outlines a few different approaches.
And the choice really depends on where the tumor is located and the surgeon's preference. The standard for many surgeons, especially for mid-esophageal tumors, is the Ivor-Lewis esophagectomy.
What does that entail?
It's a 2-phase operation. Phase 1 is in the abdomen, either open or laparoscopy, where you mobilize the stomach and turn it into a tube. Then, phase 2 involves a right thoracotomy, opening the right side of the chest to remove the esophagus and bring the stomach tube up to connect it.
Hold on, why the right chest? I thought we established the esophagus has all those left-sided curves.
But in the chest, what's on the left? The heart it gets in the way. The right side of the chest gives you this huge, clear window to the entire thoracic esophagus. It's much better exposure.
That makes sense. What of the McKeown technique?
That's a 3-stage procedure. You do the thorax part and the abdomen part, but then you add a third incision in the neck. You make the connection, the anastomosis high up in the neck.
Why go to the trouble of a third incision?
It's all about safety. An anastomotic leak is the most feared complication. If that connection leaks in the chest, you get mediastinitis, and it's often fatal. If it leaks in the neck, it's messy, it's a problem, but it's manageable. It drains out onto the skin. So some surgeons prefer the safety of a neck anastomosis.
And the transhiatal approach.
That one is abdomen and neck only. You don't open the chest at all. You put your hand up through the hiatus and the diaphragm, and you literally strip the esophagus bluntly from the mediastinum.
Bluntly sounds rough.
Yeah, it is. It's a blind procedure in the mediastinum. It's quite controversial. It might be okay for a very distal adenocarcinoma, but for mid or upper cancers where you need a good lymph node dissection, many believe it's oncologically inferior because you can't see what you're doing.
And finally, all of these can be done with minimally invasive MIE techniques.
Right. Replacing the big open cuts with thoracoscopy and laparoscopy. It's the way the field is moving to try and reduce pain and speed up recovery from these massive operations.
So we have traveled the winding road.
We have indeed.
Let's wrap this up with our outro and a final recap. This was the Ready Reckoner for Baily and Love, Chapter 66.
Let's hit those mental anchors one last time.
The anatomy. Remember the curve. It's left, right, left. Approach the neck from the left, but watch out for that recurrent laryngeal nerve that hugs it tight on the very same side.
The motility. Achalasia on a barium swallow looks like a rat's tail. Diffuse spasm looks like a corkscrew.
The emergencies. Mallory Weiss is a tear, which means bloody vomit. Borhave is a burst, which means air in the neck and a crunching sound over the heart.
And finally, remember the paradox of the OGJ.
This is the final provocative thought I wanted to leave everyone with. It really stood out.
It really struck me reading this chapter. When we treat achalasia, we cut the sphincter to help swallowing. We intentionally break the anatomy to fix the physiology.
Right.
But then, because we broke it, we have to create a new valve, a fundoplication, to stop the reflux.
We break anatomy to fix physiology, then we have to fix the anatomy again to save the mucosa from acid. It just highlights the incredible delicate balance of the OGJ. It's not just a flap. It's a complex, high-pressure system.
It certainly is.
So that is your scaffold. Now, your call to action. Go open Baily and Love, 28th edition, Chapter 66. Read the text, look at the diagrams, and fill in the breaks.
Good luck with your studies.
Thanks for listening to The Deep Dive.
Stay curious.